Go. Okay, hi everyone. We're going to get cracking. So last call to get a coffee and stuff. I guess Hillary is saying hi to some folks. We're just going to get cracking. So I want to welcome everyone, both online and in the room. I think we always have people filtering in over the last first 5-10 minutes. I will start with a land acknowledgement. And Rachel, I've got the camera working right. Yep, okay, perfect. So Ottawa is built on the unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land, as well as all First Nations, Métis, and Inuit people. Today we have a resident presentation from a group of our PGY3 pediatric residents. So Dr. Emily Hawling, Dr. Emily Kornelsen, Dr. Carinna Moyes, and Dr. Heidi Reinhardt. They are all third-year residents, and they have a pithy group bio, so I'll just read that. So while their individual clinical interests span a range of pediatric subspecialties, they share a unified appreciation for the important role that high-quality sleep plays in child health and development. And I was just joking them also with adult growth and development, I think. Together, they will explore this topic specific to children with neurodevelopmental diversity and highlight its relevance to general pediatric practice. So I'll hand it over to you. Thank you.
So thank you all so much for making the time to come to our chat on addressing sleep challenges in children with neurodevelopmental disorders. And we'd also like to thank Dr. Myron for providing us with guidance on this talk. How do we make the slides go? Yeah. Okay, here we go. I figured out the technology. So this talk is based on a recent CPS statement, Sleep Matters, supporting healthy sleep for children and youth with neurodevelopmental disabilities. In terms of our goals for this chat, we'll begin by discussing normal sleep architecture and the importance of sleep. We'll then talk about the prevalence and some common sleep disturbances in children with neurodevelopmental disabilities, as well as a structured approach to assessing sleep problems, identifying how to assess for secondary factors, and then how to work in collaboration with patients and families to develop individualized approaches for intervention focused on behavioral strategies with medication as an adjunct when needed.
All right, so I'm going to start us off with a bit of background information on sleep. So we'll start with what is sleep. So I think everyone has a general idea of what sleep is, probably involves thinking more about the behavioral state of you're lying down, your eyes are closed, you're resting. But the definition, so it's a reversible behavioral state of perceptual disengagement from and unresponsiveness to the environment. But it's so much more than that. It's also true that sleep is a complex amalgam of physiologic and behavioral processes. So with respect to the structure of sleep, the sleep cycle can be divided into 4 stages that repeat approximately every 60 to 90 minutes, with the length of that cycle varying depending on age, with infants having about 50-minute cycles and then it extending throughout childhood. And it can broadly be divided into non-rapid eye movement sleep and rapid eye movement sleep. So during the non-rapid eye movement sleep, so NREM, you have relatively low brain activity, but the regulatory capacity of the brain remains active and body movements are preserved. It's divided into 3 stages, so N1, N2, N3, N1, which is light sleep, N2, which is deeper sleep or the initiation of what we think of as true sleep, and N3, which is deep, slow wave sleep, which is the most difficult to be awoken from and the most restorative. And then we have rapid eye movement sleep. So this is physiologically most like wakefulness. You have your highest metabolic rate. It's characterized by muscle atonia. So your muscles are paralyzed aside from your diaphragm, extraocular muscles, and your middle ear muscles. And this is when dreaming occurs. There's also brief arousals typically that occur at the end of each cycle. So sleep architecture, which is the pattern and proportion of the different stages within cycles, it varies throughout the night. You have more slow wave sleep at the beginning of the night and more REM sleep at the end. It also varies throughout the lifespan and is impacted by activity, alcohol, medications, as well as level of pre-sleep arousal and breathing difficulties. So here is just an overview of, you can see how sleep architecture changes over the lifespan. So on the left, we have a hypnogram, which is a graphic representation of the various stages of sleep. So you see at the beginning, children, then young adults, then the elderly, and then on the right you have the proportion of the various stages of sleep throughout the lifetime. You have a decline in REM from birth of about 50% into adulthood, which is 25 to 30%, and you have a predominance of slow wave sleep, which peaks early in childhood and then drops off after puberty and further over the lifespan. So the next question I aim to answer is, when do we sleep? So it's governed by two different processes that occur simultaneously. We have the homeostatic process, which is possibly related to adenosine or other somnogens, and they increase while you're awake and decrease while you're asleep. So it tends to increase with wakefulness and decrease during sleep, and it tends to build more quickly in infants and young children. And then we have the circadian rhythms. So this is the clock-dependent cycle, and it's governed by the suprachiasmatic nucleus, with melatonin being the primary biomarker, and it needs to be synchronized by environmental cues, with dark light cycle being the most powerful, but also meals, physical activity, and alarm clocks. And here's just a graphic representation of the two different processes working together. As you can see, you have the highest sleep pressure when the difference is the greatest. So it's indicated by the sleep gate there, and that's when you fall asleep. So next question is, why do we sleep? So despite extensive advancement in our knowledge of sleep over the past 50 plus years, the precise biological function is still somewhat of an enigma. What we do know is that it's required for survival and that it's essential for physical, cognitive, and psychological health and overall quality of life. So theories and data we have shows that sleep has a role in energy conservation as well as restoration, and that's both at a cellular level and a more like holistic global level. I know I am currently post-call and am not feeling at my best, both cognitively and physically, plays a role in physical health. So it's important for immune function, pain perception, cardiometabolic health, and growth and development. In fact, growth occurs most during sleep, with highest growth hormone secretion during sleep, as well as cognitive functioning, memory, and learning. Particularly, what was I going to say? So consequences of poor sleep, I think we can all recognize them in ourselves and have seen them in others. So there's cognitive, emotional, and behavioral sequelae outlined here, but essentially fatigue and lethargy. You can have increased somatic complaints, mood disturbances, cognitive impairment, daytime behavioral disinhibition, as well as poor impulse control and increased risk-taking behaviors. This can lead to academic problems and can lead to use of stimulants or other substances to sort of combat the effect of daytime somnolence. It's associated with negative physical health outcomes. So there's increased risk of accidental injuries and car crashes, impaired cardiometabolic health. It's associated with obesity and decreased insulin sensitivity, which can increase cardiovascular risk later in life, as well as increase susceptibility to infections. And it doesn't just impact the children, it impacts the family. So it can poor sleep in the children can lead to insufficient sleep in the family, higher parental stress, and poorer parental mental health. Briefly, just going to define what healthy sleep is. So it's more than just the absence of a sleep disorder. It's characterized by subjective, caregiver-rated satisfaction, appropriate timing, adequate duration for age, high efficiency, sustained alertness during waking hours, and healthy sleep behaviors. It can be remembered by the dimensions of healthy sleep can be remembered by the acronym BSATED. So behavior, satisfaction, alertness, sleepiness, timing, efficiency and continuity, and duration. We have information and guidelines specifically about duration. So coming from the American Academy of Sleep Medicine, which is recommending sort of following amount of sleep throughout the lifetime. So as you can see, over time, the amount of total sleep during the 24-hour period decreases. In terms of sleep disturbances, so it can be divided into a few general categories, with insomnia, which this is being the most common, particular behavioral insomnias, as well as, so you have circadian rhythm sleep-wake disorder. So this is when you have a misalignment between the internal circadian rhythm and the external environment. Sleep disordered breathing, or OSA, central sleep apnea, parasomnia, so this is like undesirable physical events or experiences during sleep, including sleepwalking, sleep talking during non-REM sleep, and nightmares or REM sleep behavior disorder during REM sleep. Hypersomnia, so excessive daytime sleepiness, which would include narcolepsy, sleep-related movement disorders such as restless leg syndrome or periodic limb movement disorder. So this is the general categories, but I want to discuss how sleep disturbances manifest in individuals with neurodevelopmental disabilities. So when I'm talking about neurodevelopmental disabilities, this refers to individuals with genetic conditions that affect neurodevelopment, as well as those with neurodevelopmental disorders defined by the DSM-5, including what I've listed up there. So there are some similarities between individuals with neurodevelopmental disabilities and typically developing children. So they have a similar range of sleep issues, and they also are most commonly affected by behavioral insomnias, such as bedtime resistance, prolonged sleep onset latency, waking during the night, or waking too early. And these do usually respond to the same interventions for optimizing sleep habits, so sleep hygiene, as well as behavioral interventions. But there are some key differences and considerations. So one, the rate of sleep disorders in individuals with neurodevelopmental diversity is greater than 80%. And so that is higher than the typically developing population, with estimates of sleep disturbances between 9 and 50%. As well, they tend to be more chronic. The intensity in general of sleep disturbances tends to correspond to the global severity of their neurodevelopmental disability. The management strategies may take longer. They may require additional steps. They're also more likely to have more than one sleep disorder. They have a higher prevalence of medical and psychiatric comorbidities, such as epilepsy, reflux, etc., which can have a bidirectional impact on sleep. They're also more likely to be on medications that can contribute to sleep disruptions, such as anti-epileptic medications, stimulants for ADHD, as well as psychotropic medications. Assessment and treatment may be more complicated due to a variety of reasons. So one, the multifactorial etiology, two, communication difficulties or difficulties understanding. There can be sensory differences as well. And sleep problems can exacerbate the existing developmental and behavioral challenges, which just emphasizes how important it is to identify and manage sleep disturbances in this population.
So now that we have a general sense of, one, what is sleep, why is sleep so important, and how it impacts this population particularly, something that's highlighted very clearly in the CPS statement is how to properly assess sleep. So it emphasizes that we need to use a structured and systematic approach in order to assess it properly, integrating screening tools, a very detailed sleep history, sleep diaries, consideration of all the socioecological factors, evaluation for secondary factors, as we started to mention, and selective use of investigations. The ultimate goal is to efficiently identify the sleep problems and guide targeted management rather than relying on extensive testing. This nice pyramid is in the CPS statement, and as any good pyramid does, you have a very strong base that starts off with the screening and kind of ruling out any secondary causes contributing. When it comes to screening, we probably are mostly familiar with the Epworth Sleepiness Scale. So this scale particularly looks at hypersomnolence or excessive daytime sleepiness. So it's a scale that takes a variety of different activities you might be doing through the day and then gauging how likely you are to doze off during said activity. So 0 being I never doze off, 3 being high chance that I'm dozing off while I'm sitting and reading a book. And then we score that all together, and then it identifies how bad the daytime sleepiness is. Scores greater than 11 generally tend to identify some concerns with sleep. There's a number of considerations in the pediatric population to think about when you're using this scale. There is a modified version that can help, but the clinical use, always keep in mind in the context of the patient, which can kind of skew some of the answers. Particularly in our age group of 2 to 12-year-olds, the CPS statement outlines one called BEARS, which is really just broad headings for a number of different things related to sleep that we can screen into. So particularly bedtime problems around the time of going to sleep. It identifies the excessive daytime sleepiness as well on this scale, nighttime awakenings for a variety of different reasons, the regularity and duration of sleep, as well as any factors that might be suggestive of sleep disordered breathing. In our adolescents, they're greater than 12 years. The statement also mentioned the Adolescent Sleep Hygiene Scale, which is actually a scale that's looking at how good your sleep is or how good your sleep hygiene is. So it has a number of different questions, and it'll say, this never applies to me or this always applies to me. And you would get a score of 6 for never. So actually a higher score is indicating that you have better sleep hygiene. Now, once you've done your screening, you've identified a patient that is higher risk, or you may want to investigate a little bit further about sleep concerns. Your sleep history is your most important tool that you have. So you're going to be asking a number of different questions in kind of a few different main kind of subcategories to really identify, one, is there a big sleep concern here? But 2, where can I sort of target and where are the specific issues? So in terms of nighttime sleep, your onset, how long is the sleep? Are you waking up at night? Which you may start to have identified in your screening tools, but you want to get more into the details of that. Beyond just the immediate sleep complaints, you do also want to ask about their longitudinal history and their sleep patterns over a longer time period. You want to look at, what does the environment look like? Are there screens around? Are they sharing room with other people? Are there noises interrupting their sleep? And then their daytime functioning. So we may have also gotten a little sense of this on our Epworth screening scale, but how severe and how functionally impacting is the daytime sleepiness? And are they not able to go through their activities during the day? Are they having behavioral and emotional dysregulation as related to their poor sleep? And then, of course, looking at all of the different medical factors that could be contributing to their difficulties with sleep. There's a nice mnemonic that this statement refers to that kind of just broadly allows us to remember a lot of the different important features around sleep. So it's called the ABCs of sleeping. I won't go in detail of every piece, but it's just a lot of things you should really be considering when you are taking a good sleep history. One in particular that I don't know if I've necessarily thought off the top of my head initially before reviewing this is just making sure that the child's needs are met during the daytime, so that we're not getting to the point of wanting to fall asleep and they're like, this hasn't happened, I still need this, and there's a lot of outstanding needs, which not only delays onset of sleep or may not let them kind of sleep throughout the night. So this is a nice mnemonic that kind of reminds you of a lot of those key features that we want to know about. The sleep diary is an incredibly useful tool that we can get a lot of this information through the family recording it at home. We need to get at least 7 days of data to properly get any kind of trends or good sense of what might be contributing to the difficulties with sleep. So we want to see, what are the sleep patterns looking like? What's the variability? What are the potential triggers that are confounding and then leading to these difficulties with sleep? What are the sleep-wake times? How many times a night are they waking up? Are they taking daytime naps because they're so tired? The family will come to your clinic with this diary, and as long as they've had at least 7 days at minimum, but ideally more of information, you can start to identify some of those trends with them. The CPS statement includes this diagram that specifically tries to make everyone think about the sort of broader picture around a child's sleep. So a lot of the different socioecological factors, not only the individual factors of the child itself, but thinking about the family and the dynamics and what else is going on in the home that might be contributing to difficulty with sleep, as well as even thinking broader than that and looking more at what's going on in the neighborhood and the culture around them, and thinking about all the potential contributing factors so that we can incorporate that later into the management that we'll talk about. And a key piece of this is going to be asking about and assessing for any kind of secondary contributing factors that might be impacting their sleep that we can intervene on with various, whether that be medication or other strategies. So a lot of the patients in this population often suffer from reflux. A lot of them end up having different conditions that lend itself to developing OSA or sleep disordered breathing. They might have cavities, they might have constipation, they might have various things that are causing pain or discomfort, which is disrupting their sleep. They may actually be having seizures overnight, which may not be identified fully. They may have feeding schedules where they have tube feeding throughout the night, and that could be waking them up or disrupting their sleep. Or, as was briefly mentioned by Emily, there may be medications that they are already on that would be interfering with their sleep. For example, stimulant medications for ADHD, various seizure medications, could be impactful and should be very carefully reviewed during your extensive history that you'll be taking. Now, the statement highlights that for the most part, your history and assessing the story around their sleep is the most important thing, and your biggest tool and biggest investigation tool is actually your sleep diary. But they do identify 2 other investigations that show some evidence to be high yield, and one of which is actually the ferritin level. So we do know through different research that targeting higher ferritin levels, particularly above 50, are recommended to support good sleep. There's some research to suggest it's the ferritin level that ends up in the CSF fluid, but it's also ferritin that is able to get converted into various neurotransmitters that help function as a part of sleep quality. But then also a part of that is wondering about if periodic limb movement is contributing at all to the sleep difficulty, and it can help with that. The other main investigation that everybody thinks about and wonders, should I send my patient for, is the sleep study. So I wanted to focus a little bit more on that. So in terms of our sleep studies or polysomnography, we know that unfortunately they are difficult to get. The resources for such are quite limited and there's a high demand, but there are very key sort of indications for when we should be referring and should be thinking about a sleep study. We all are very well aware of OSA, or obstructive sleep apnea, as one of our various sleep-related breathing disorders. But if there's a strong history of recurrent snoring, even witnessed apneas, gasping, labored breathing in their sleep, any of these things are very high red flags for disordered sleep breathing. And this population in particular, for various reasons, could be more at higher risk for this, whether that be related to their tone, related to any syndromes or conditions that they have along with their neurodevelopmental disability, whether they have different architecture of their face or different craniofacial anomalies. All of these things would contribute to the risk for OSA. Also, our sleep studies are often used in a pre or post evaluation for surgical interventions, so our adenoid tonsillectomies, for CPAP, BiPAP initiation, of course, and even titration if that needs to be changed. And then some other indications that you may consider a sleep study for, which may or may not come along with our latency testing as well, is your suspected narcolepsies, hypersomnias. If you're worried about a periodic limb movement disorder, that often sometimes just incidentally gets picked up on our sleep studies. If there's atypical or concerning parasomnias that you want to elicit a little bit further, or other nocturnal events that we still can't fully elucidate, sometimes the sleep studies can actually really help us differentiate whether there's seizures overnight or not, when the EEGs aren't always fully diagnostic. It is the gold standard for identifying sleep disorder breathing overnight. Unfortunately, home sleep studies are not yet validated in children. There is some validation in adults, but there is not enough evidence to validate them in children as of yet. Dr. Ursula recently did a talk for us that is suggesting that maybe there is some funding coming our way to start seeing if home sleep studies might be a possibility, if there's more research kind of behind that. And then, as I mentioned before, neurodevelopmental disorders tend to have higher risk of these conditions for various reasons that I mentioned. So if there's a high suspicion, there's a lot of red flags, definitely refer. There are some things that I do tend to see in the community that we do while we're awaiting that sleep study to try to beef up our consultation, whether that be we've tried the nasal steroids already, hasn't made a difference, or we've done an overnight oximetry, which of course is not diagnostic, but then can kind of emphasize our story a little bit when we do refer to respirology or ENT.
All right, and then we're going to talk about the management, that behavior management. It's important when you are doing the counseling for the families to check what is the biggest difficulty they are having. If it's related to the child being not ready for going to sleep because they are not tired yet or they are overstimulated, for example, you see like the two down like the orange and purple, or it's because the family does not have like a sleep schedule in place, or if they are involving activities that are not matching like the sleep readiness for the child, and the orange and the other purple on the other side, or if, for example, the child associate the bedtime with a bad situation in which they are grounded when they are sent to bed, for example, or if they are doing activity too much stimulating before bed. But you're gonna say, do really the change in behavior, like the sleep hygiene and counseling in behavior changes work? So there was this like systematic review about RCTs done with behavior changing in child with ASD, published in 2019 by CHEO and collaborators, that they managed to get 3 good studies that were randomized controlled trials with the interventions and non-interventions in patients with ASD between 6 and 10 years of age. And then the interventions included either giving a pamphlet and doing discussion with parents, or doing cognition behavior therapy and following up with the families, or doing specifically counseling with sleep and checking the result of that. And they measured the sleep of the ASD children with like the watches, the actigraphy watches, or they did a questionnaire for quality of sleep. And what they found was that the changes, the intervention increased the amount of, like, overall amount of sleep of the ASD patient in 25%, and as well reduced the time for the children to get to sleep after intervention by 70 minutes. So it's nice that we know that it works. And then when you are discussing which interventions or what things you should do, you can divide the changes in around 4 areas that you will counsel. Are you going to counsel about the sleep environment, the sleep routine, working on physiologic cues to sleep, or the sleep schedule? And because it's difficult for these measures to get in place and to be effective, you need to always go back and forth with the caregivers, highlighting that these will pay out in the long term. The child will not only get stable in the routine and it's going to get easier, but as well, they will be less irritable during the days. But you need always to encourage the families. It's not going to be something that is going to be a quick fix. So you need to have patience when you're working on that. And it's important also to mention that in the CPS statement, they have very good, useful tools for parents and families in various languages. There is one that is in 23 different languages. So I really recommend, if you need tools for parents and caregivers, to go to the CPS. So now talking about the sleep environment, when you are discussing this with families, screens is like a no-no in the bedrooms, like involving cell phones, any kind of screens, nothing there, like nothing that is like a loud source of noise, like the radio or things like that. You need to aim for like a dim light or darkness, and then dim light is going to be something in the orange yellow, not something bluish. You need to aim for like very low noise or nothing. And then for parents that are concerned, for example, because these patients, they can, as Carinna said, develop seizures overnight, you can discuss if they can have like some cameras and monitoring, or if they are sleepwalking as well, the parents can watch them. So then they are aware, like this, keep the safety of the patients. Then when you're talking for this specific population, some additional issues might be helpful. You can discuss the weighted vests or blankets for some of them that are neurosensitive, so then this might be helpful. And then the white noise generation is something that is like a little bit fancy now. People use like all these white noises. And when I was looking for the research about it, although there is not much in place, I found that as long as you are avoiding these volumes exceeding the 91 decibels that can be damaging for the hearing, most of the studies didn't show interference in the daytime cognition or like in the daytime activity of the children. None of them were bad or like impacting the developmental, so there is nothing that advising against the white noise. And the last tool that you can use some for this, especially these populations, they can have like transitional object, like a favorite blanket of toy that I associate with that bedtime and keep them comforted during that time. Now, when you're talking about the sleep routine, I really recommend these like Autism Speaks. If you're looking for families, they have some good videos specifically for ASD, giving the tools and the suggestions to the parents. One thing that you need always to encourage the parents is to avoid to be in the presence of the child when the child is about to get to sleep, to not create this memory that the parents need to be there. You need to always recommend avoiding the screens 2 hours before bed, as well as like highly physical activity, like things that are very exciting 2 hours before there, and recommend more calming things such as playing Lego, coloring, or reading, or like listening to stories. Some of these populations, they like these repetitive, gentle movements like brushing or putting creams. You can work with that. And for them, the pictorial schedules are very good too. So here you have the samples of these picture schedules. They are available online for printing, and you can change for the drawings for like pictures of the child involved. And you can have as either as like this checklist if the child can read and is older, and then they can do the checklist. This help them to also follow their routine, or you can work with the pictures that they can either do Velcro and gluing on for the children that are not verbal and do better with like visual clues. Another part that Carinna mentioned as well is the physiologic use during the day. So if the child is not ready and if they don't have their needs met during the day, of course it's going to be more difficult for them to get to sleep. So always important to encourage exercise for at least 1 hour a day. It doesn't need to be continuous exercising. They can go for a walk with the dog 10 minutes. They can jump in the trampoline 10 minutes. But as long as you're trying to aim for this 1 hour a day, this might be helpful. You need to pay attention at the timing of the meals. If they do like a heavy meal before 2 hours of going to bed, this might increase their chances of reflux or also feeling not very well. And in this population, highly recommended to avoid caffeine. With the sleep scheduling, sometimes these children try to wake up late during the day, and the parents or the caregivers say, "Well, but I get so many things done at that time," and they don't feel very much encouraged. But the end is that the child's gonna go in bed late to bed, like 1 a.m., 3 a.m., and then this is gonna cause a disturb in everyone. So the best thing for you to do is try to always involve the caregivers in waiting what's the best, and if they decide to go for the change, you can recommend they can shortening the time that they are like the waking time by 30 minutes. So if, for example, the child wake up at 10, you can suggest start waking them up at 9:30 regularly, and then you can do this for like between 3 to 7 days, and then you go like 9 and then 8:30, and then this is going to help them to go back to bed early, because they will have that sleep pressure a little bit earlier than later. So you can help with that as well. And also in the CPS statement, is like Autism Speaks, they have a good video for like physiologic cues and suggestions. So I think it's another important tool for parents and families. And lastly, when you are talking like about with these caregivers and families, you always need to think about the caregiver. These are not going to be easy and quick fix solutions or strategies. So sometimes even the caregivers might have their sleep involved, and then they might not be feeling well. So if you're noticing that this is a big issue, you could try to discuss, for example, respite care or night nursing in between the process to make your goal be achieved.
So Heidi really highlighted the cornerstone of our sleep management, which is these non-pharmacologic behavior strategies. I'm going to talk about the select situations where pharmacologic strategies may be used with caution as an adjuvant. So, pharmacologic management of sleep disorders is not first line and should always be used in conjunction with these non-pharmacologic strategies. It's important to know that there is no licensed medication for pediatric sleep for children, so any sedating medication that is being used to promote sleep is being done so off-label, and the family should be aware of this, and it should be done with caution. So, in terms of counseling a family before prescribing medication, and it is quite common that families are looking for medication, you want to make sure they're aware of the limitations of medications, that they're continuing with those ongoing behavior strategies. You also want to make sure they're aware of potential side effects, and it's very important to counsel on withdrawal because a lot of these sedating medications can have very serious withdrawal if they are stopped suddenly without medical guidance. Another important thing is to counsel on medication timing. So being aware of the pharmacokinetics and dynamics of the medication and how soon before desired sleep time it should be taken so that that can line up with the non-pharmacologic strategies. And it's also really important to always have a clear goal and exit strategy that you decide together with the family. So for example, you could say, we're going to trial a medication and our goal is that within 1 month, our sleep onset time will be under an hour. And if we don't achieve that, we're going to reevaluate. We may stop this medication and consider another one. And this is important for avoiding ongoing medications with side effects that aren't working for the child. In terms of things to think about when choosing a medication, you want to think about low dose and short duration. Ensure you're aware of any comorbidities the child may have. Be aware of polypharmacy, including asking about over-the-counter medications. And there's a number of nutraceuticals that families will use for sleep, so very important to not just ask about prescription medications. You also want to make sure you're matching the sleep problem to the medication. I'll talk a bit more about this later, but for example, if the child's issue is falling asleep, then a medication that helps them stay asleep isn't useful, or vice versa. You want to be very aware of the side effects and also the unintended effects that these medications may have on sleep architecture. I'm going to speak most about melatonin because we have the most robust evidence for melatonin, and it is typically going to be your first choice for a pharmacologic agent that you're going to reach for before considering these other sedating medications. So very briefly, I'm sure you're all aware melatonin is a hormone that's secreted in response to decreased light. At physiologic doses, it helps with this phase shifting between wake and sleep. At supraphysiologic doses, it has more of a hypnotic effect. And typically we're going to be using it at these supraphysiologic doses, and that is what most of the research has been done on. So in terms of sleep architecture, melatonin primarily targets sleep onset. Oh, I hear myself. Okay. And then there is some emerging evidence that extended release melatonin may also have benefits for sleep latency. And there is particularly strong reasons to consider melatonin in children with neurodevelopmental disorders because they have higher rates of circadian mediated phase delay, which can be improved with melatonin. In terms of where to start with melatonin, a typical starting dose is around 1 to 3 milligrams, and typically you'd max out around 10 milligrams. And you want to give this about 30 to 60 minutes before the desired sleep time. And you want to make sure that in those 30 to 60 minutes after they've taken it, they're really focusing on those non-pharmacologic things. So that good, sleep routine, avoiding stimulating activities, positive sleep onset associations, all of those lovely things that Heidi talked about. Melatonin does have some potential side effects. They are primarily mild. Common ones would include things like daytime sleepiness, headaches, dizziness and nausea, and mood swings. Some more severe side effects that there's controversy around would be things like HPA axis suppression. This was seen in animal studies but has not been replicated in human studies. And then there's also some question around whether or not there could be immune reactivity changes, again, mostly based on theoretical modeling and not as much seen in actual human studies. In terms of the evidence base for melatonin, it is more robust than the evidence base that we have for any of the other pharmacologic interventions. So, especially in children with neurodevelopmental disabilities, and a lot of the research has focused on ASD, we do see physiologic differences in melatonin levels compared with controls. So we already have like an extra probable reason why melatonin may help this population. There's also been RCTs, systematic reviews, and meta-analysis that have shown reduced sleep onset, and these include studies specific to children and children with neurodevelopmental disabilities. Studies have also shown treatment satisfaction and improved quality of life, and the International Pediatric Sleep Association does actually recommend the use of melatonin in children with neurodevelopmental disabilities after the use of non-pharmacologic strategies has been trialed. One really important consideration with melatonin, though, is that there is currently no licensed pharmaceutical grade product available. And so these nutraceuticals are less tightly regulated, and there's a chance that when they're purchased, the family may not be getting the exact dose that they expect, and there is potential risk for contamination as well. So just something to be aware of. And also, if your intervention isn't working as you expect, maybe look at like where they get their medication, what formulation, is there a different formulation they could try? I'm going to very briefly touch on other sedating medications. This is not the focus of the talk, and I'm going to talk more about how we can use general principles to work through choosing a medication rather than the details of each specific med. So I wanted to do this in the context of a case. So we have a 7-year-old female. She has ASD, ADHD, obesity, and OSA, and is on bifenton and melatonin. She has significant challenges with sleep onset, taking several hours a night to fall asleep, which is leading to daytime fatigue. She is falling asleep at school, and it is having a significant impact on her quality of life. She has had previous behavioral strategies, including working with an occupational therapist. She's had a TNA for her OSA, and that is now well controlled, and she has trialed melatonin. So we are now at the point where we could consider another sedating medication. In terms of a goal, this is going to be based on shared decision making with the patient and family. And in her case, the goal is to fall asleep within 1 hour and to be able to stay awake throughout the school day. So this is a summary table from the CPS statement, and I apologize because it is a little hard to read on the slide, but I wanted to talk about how I could use, it's a fairly high level summary table, but this to guide management. So for her goal is sleep onset. So the first thing you want is a medication that's going to achieve your goal. So you want to think about meds that target sleep onset. So ones that they suggest would be antihistamines, clonidine, guanfacine, or trazodone, and avoid ones that are really targeting sleep latency, especially because some of them, like gabapentin, could actually worsen the sleep onset. In terms of side effects, it's important to be aware of the side effect of any medication you're using. And one thing you'll want to counsel on, especially in this patient, her goal is to be awake at school. All of these medications have a potential side effect of daytime sedation. You also want to consider how side effects can interact with comorbidities. So here, this patient already has obesity and OSA. So you'd really want to avoid medications that could potentially worsen that through metabolic side effects. So something like an atypical antipsychotic would likely not be a good choice in this patient. You can also consider if there's any evidence specific to the patient's comorbidities. So in this case, the patient has ADHD. So there is some evidence and studies that have been done on clonidine and guanfacine in these populations. Though I will note the randomized control trial done on guanfacine was stopped early because of worse sleep outcomes in the treatment than the placebo group. The next thing is to consider the evidence base. So there is no robust evidence for any of these medications. So the medications that I've highlighted in red have not been studied in children, so trazodone or not been studied for sleep in children. I apologize. So things like trazodone or atypical antipsychotics. The ones highlighted in orange have been studied, typically small low quality studies, and they have not shown significant efficacy. So things like antihistamines, benzodiazepines, and guanfacine. The ones in yellow have shown some potential benefit based on small, low-quality studies, primarily retrospective chart review. So things like clonidine, doxepine, and gabapentin. And so I don't want to specifically recommend one medication over the other for sleep. I really want to emphasize that you want to think through the medication systematically, think about what your goals are and how these medications and their unique properties could fit within those goals. And the table in the CPS statement can definitely act as a starting point for that.
So that was quite the whirlwind around sleep, and particularly in this population of patients. But some of the really high yield take home points that we want to emphasize for everyone is how foundational sleep is, which I think everyone already appreciated before this. But identifying how significantly sleep problems affect our patient population with neurodevelopmental diversity. Always ask about sleep. And every time you're seeing one of your patients, screen them. Ask about their sleep. Try to identify these problems early. Behavioral strategies, as we emphasized many times, always come first. Consistent routines, optimizing the environment, caregiver-supported behavioral approaches, all of those things are your very first line. And they often require a lot of time, consistency, and flexibility. Rule out the medical contributors, the pain, reflux, sleep disordered breathing, iron deficiency, other medication effects. Make sure that those aren't contributing and try to mitigate them as you can. Use melatonin thoughtfully. So we learned a lot about how it can be really helpful, but do always consider all of these additional side effects and other pieces around that. Medications don't equal healthy sleep. Sedating medications may alter the sleep quality and architecture, so we need clear goals, and as we mentioned, exit plans are very important. Support the families. Effective care is individualized and going to be very specific to each person. Be culturally sensitive and grounded in partnership with the caregivers, because this is going to be a long process. This is not going to be a fix overnight. Thank you for listening. Any questions?
Thanks. That was great. I was just reflecting, like, I both learned a lot, but also raises a lot of questions. And so, a really good presentation that prompts people to think about things. So that being said, I have a list of like 10 questions, but I'll open it up to the floor and to Alex is like jumping to ask a question, and then, but we'll go with Priya first, and then we'll go to online, and people online can also put their questions in the chat. And just a reminder to repeat the questions from the floor. All right, Priya.
Great presentation and overview, and I love the breakdown of everything. I just was more putting in a plug for our neurodevelopmental health team, like supports at CHEO. So any child who has a diagnosis of autism can look.
Priya, do you want to give your plug up here? So we're going to repeat it, but yeah. Service announcement. Yeah.
Hi. So just making a plug for the Neurodevelopmental Health Team Foundational and Family Services. So if you do encounter a child who has a diagnosis of autism, you can go through One Call, One Click, and they will have an intake worker who has, I think there's 2 different workshops for sleep we have. One is for any child going in for a sleep study, so they can have a supported visit there, or we have regular workshops where families can come in and then schedule one-on-one time for, I guess, individualized advice. So
you don't have to go through One Call, One Click. You can just sign up on that.
Oh yes, you're right. On the website itself. So send them to the website and self-refer to. Yeah, you're right. Thank you for that.
Okay, thank you. Thanks for the public service announcement. Okay, we have a question from the chat, and then we'll go to Alex next. So, is there a maximum weight for weighted blankets or vests per the age or weight of the child? Is there an age or other indication to not use weighted blankets or vests?
This is a great question. I think there is some evidence, and occupational therapists can help with like fitting this. I know in the school board, if you're going to use one in the classroom, you need an occupational therapist to fit it. I think in general, you want to avoid them in children under 4 years. And then I believe I've read like half a pound per some amount of, I would have to look up the exact guidelines unless Dr. Myron knows.
Unaware of exact guidelines on weight blankets. I find that it's very, very, not to go against my OT colleagues in its efficacy. And if it works, great. If it doesn't, move on quickly.
Yeah, and just note, I did buy a weighted blanket for one of my kids, and there are CSA or Health Canada guidelines. I think that I looked up. I can't remember which one.
Never in an infant under 1.
Yeah.
And in a child with a mobility concern or an airway or breathing concern, I would be very concerned. It's cerebral palsy.
Yep.
I'll just repeat that for the camera. So never under 1, and never if there's a mobility concern, an airway concern, or cerebral palsy. Otherwise, there are CSA guidelines that can be looked up, but we don't know them off the top of our heads.
All right, and then we'll go to Alex.
So I study rare diseases. One of the disorders we study is an autism disorder caused by a loss of a gene which encodes a scaffolding protein. It's upregulated by DHA, omega-3 fatty acids. And one of the prime problems with it is actually sleep. And it made me go down this rabbit hole where there's studies showing that basically, and this may have been mentioned earlier, omega-3 status, DHA and EPA, can inform sleep behavior. And in point of fact, for children in these situations, with or without this mutation who are omega-3 depleted, high-dose DHA and EPA has been shown in systematic reviews to make a difference. Maybe you guys had covered that.
So just in brief, Alex was asking a bit about the physiology of sleep in this population, pointing to a rare disease where there's a scaffold protein impacted, and that DHA and other omega-3 fatty acids in high dose may be beneficial. And then Hillary put her hand up.
And now I forgot my question.
I have that effect on people. So. Okay, we can chat afterwards. At any rate, so we're doing a small trial with this. We're using actigraphy to study sleep fragmentation. And is that something you guys mentioned as well? Yeah, it really is a very effective way.
It's a really good point. We really used the CPS statement as our jumping off point, and it's not mentioned in there, so it wasn't something that we looked into extensively, but it's something that I definitely want to read and learn more about. So the use of omega-3s for sleep, and I mean, I imagine they're a very safe medication, or can be
Yeah.
How do you measure it? You said they were low. How do you know?
So there's a membrane, a red blood cell membrane levels called the omega-3 index you can use. And if you really want to get very fancy, Stephanie Bennett across at the RGN is a lipidomic person, and she can measure the actual DHA version, which is present in the brain. So there's two ways of measuring it.
Is this commercially available?
Right.
At the patient level.
Patient level omega-3 is. I think
You can check that.
Yeah, you can get that in Dynacare and things like that. I think, let me get back. Yeah, I think so.
Really?
I'll loop back.
So there was a conversation about whether there was any testing available for the omega-3 fatty acids or other markers in the lipidome, and it was unclear whether there is. Dynacare does offer some testing, but I don't know if that's actually a licensed test. I don't recall whether that is or not. So I will actually go to one of my questions before going back to the chat, and kind of tangentially feeds off that last set of questions. Sleep is such a common denominator of well-being and function. So, there's studies of intervention for sleep in the NDD population, but I was also wondering if there's any studies that have used sleep as an outcome measure for general interventions or general therapies or approaches to NDD. So, for example, behavior therapies. Is sleep ever used as an outcome to see how beneficial is this to the child with a neurodevelopmental disorder? And where my question comes from is, again, from a rare disease perspective, for mucopolysaccharide storage disease patients, we had thought about using sleep as kind of a final common denominator outcome, right? So if we were controlling pain, breathing, just interventions, it was really an anti-inflammatory intervention we were thinking of. But we were hoping to use sleep as an outcome. So I was curious in this population, have there been studies which have used sleep as a outcome? And if you don't know, that's fine, but it was, I think that's not something that came up through the
Yeah, I
preparation,
don't
but
know that
Corinna,
there was any
yeah.
specific studies that we looked at. I imagine that like sleep would be a very important parameter to include and acknowledge. However, you'd always have to think about all the confounding factors around sleep that we identified today. There are so many. So I guess that would be the one piece that would be difficult, but I think it's an incredibly important parameter and should definitely be considered.
Yeah, thanks, Corinna. And that was actually one of the reasons we didn't use sleep in the end.
You have a question with that?
I do. I have one other one though. In terms of rhythmic movement and motion and the ABCs of sleeping, it got me thinking about music, right? Because music, the tempos of music, the phrasing and structure of music is actually physiologic. It mimics our heart rate or walking rate. Have there been any studies of music as a sensory input in sleep in this population?
Well, the question is about if music was used as a behavior strategy or like to manage the sleep. When I was looking for the review about the white noise, there was nothing specific about music that they found. But what I was reading is like all these strategies with sounds, as long as the sound is not like elevated or not disturbing, there was no problem. So I think music could be one. I can look into option and get back to you. But I think it will be an okay thing.
And I think the other really important thing is that, like the sleep onset association. So if it's present at bedtime, you want it to be present when the child wakes up during the night. So if you're putting them to sleep to music, play the same music throughout the night to help their brain get back to sleep, would be an important point not to miss about how to use music.
Not Stairway to Heaven, the other two.
Yeah, I was actually thinking of Beethoven personally, but not Stairway to Heaven was Alex's recommendation. There was a question here. So did you come across any literature of orexin receptor antagonists in pediatrics? I do not know what orexin receptor antagonists are, but
Yes.
epilepsy drug.
We
Okay.
do have some of that. I believe I have a bonus slide on that if I can get my presentation to reopen. I keep forgetting
Rachel
this
might be able to put it back up.
isn't.
Oh, there it is. Yeah.
I knew we'd get asked questions about this. It should be in one of these. Or
The
do,
receptor.
Oh. I don't have it here. Yes. Yeah, there's like none available I think there's none available in Canada, which is why I ended up not including it in these extra slides about the meds. But there was some evidence. There's a great textbook that Dr. Myron directed us to for sleep disorders in pediatrics, and it does have like a page on the use of orexin. But then because it's not available in Canada, we didn't discuss it further.
Trying to get back to the chat because there was one more question in the chat.
And we have no narcolepsy treatment clinics at CHEO or in this city.
Okay, so this, we're at time. Obviously, a great presentation, lots of discussion. The last thing I'll mention is not actually a question, but a comment. There's actually a new long-acting melatonin mini tablet recently approved by Health Canada for, I think that would say treatment of insomnia in children aged 2 to, can't say 18, who have ASD or Smith-Magenis syndrome. Not yet available, but expected in 2026.
Thank you so much.
It's called, as with most drug names, I can't pronounce them, Slenito. Yeah. Okay. Well, thank you again. Great presentation.
Thank you. Great.